How chronic constipation affects hypertension, heart failure, pelvic health, and beyond. Constipation is often dismissed as a minor annoyance, a mere inconvenience in our busy lives. However, for millions, it's a chronic, debilitating condition that can significantly impair quality of life and, surprisingly, contribute to a wide array of serious health problems. Far from being an isolated issue, chronic constipation is intricately linked to various bodily systems, often creating insidious, vicious cycles that exacerbate existing conditions and spawn new ones. Let's delve into the cascading effects of chronic constipation, exploring its connections to everything from electrolyte imbalances to life-threatening cardiovascular events and structural damage within the body. Common causes of chronic constipation. Constipation occurs when stool moves too slowly through the digestive tract, allowing the colon to absorb too much water, making the stool hard, dry, and difficult to pass. While the effects are widespread, understanding the underlying causes is crucial for effective management. These causes can broadly be categorized into lifestyle factors, medications, and underlying medical conditions. Lifestyle factors, these are among the most common culprits. Insufficient dietary fiber. Fiber adds bulk to stool, helping it retain water and move smoothly through the intestines. A diet low in fruits, vegetables, whole grains, and legumes is a primary cause. Inadequate fluid intake. Dehydration. Water helps to soften stool. If you don't drink enough fluids, the body reabsorbs more water from the colon, leading to dry, hard stools. Lack of physical activity. A sedentary lifestyle slows down metabolism and reduces muscle contractions in the intestines, hindering bowel motility. Ignoring the urge. Suppressing the natural urge to defecate can lead to the stool becoming harder and more difficult to pass over time, eventually dulling the body's signals. Changes in routine or environment. Travel, changes in diet, or stress can disrupt the body's natural clock and lead to temporary or chronic constipation. Excessive consumption of certain foods. High intake of processed foods, dairy products, for some individuals, red meat, and foods high in fat and sugar, which are typically low in fiber, can contribute to sluggish digestion. Medication side effects. Many common medications can slow bowel movements. Opioid pain relievers. These are notorious for causing significant constipation. Antihypertensive medications. As discussed, calcium channel blockers, beta blockers, and diuretics are common offenders. Antidepressants, particularly tricyclic antidepressants and some SSRIs. Antihistamines, found in allergy and cold medications. Antacids, especially those containing aluminum or calcium. Iron supplements, commonly prescribed for anemia. Anti-seizure medications. Certain Parkinson's disease medications. Underlying medical conditions. Chronic constipation can often be a symptom or complication of other health issues. Metabolic and endocrine disorders. Hypothyroidism. Underactive thyroid. A sluggish thyroid can slow down overall metabolism, including gut motility. Diabetes. High blood sugar levels and associated nerve damage, neuropathy, can affect gut function. Electrolyte imbalances. As previously discussed, deficiencies in potassium or magnesium, or high calcium levels, can impair muscle function in the gut. Neurological disorders. Conditions that affect the nerves controlling bowel movements can lead to constipation, including Parkinson's disease, multiple sclerosis, spinal cord injuries, and stroke. Gastrointestinal disorders. Beyond general constipation, specific conditions like irritable bowel syndrome with constipation, IBS-C, diverticular disease, though it's also a complication, and rarely, obstructions from tumors or strictures. Pelvic floor dysfunction. As detailed later, discoordination of pelvic floor muscles, dyssynergic defecation, prevents efficient stool expulsion. Pregnancy. Hormonal changes, decreased activity, and pressure from the growing uterus commonly lead to constipation during pregnancy. Aging. As people age, metabolism slows, muscle contractions in the colon may weaken, and reliance on multiple medications increases the risk of constipation. Understanding these diverse causes is fundamental to identifying appropriate interventions and breaking the cycle of chronic constipation. The electrolyte link, when body chemistry goes awry. Our bodies rely on a delicate balance of electrolytes, minerals like potassium, sodium, calcium, and magnesium, for vital functions, including muscle and nerve activity. Disruptions in this crucial balance can both cause and intensify constipation. Muscle weakness. Electrolytes are indispensable for proper muscle contraction. When levels are askew, particularly with deficiencies in potassium, hypokalemia, or magnesium, hypomagnesemia, the smooth muscles of the digestive tract can become sluggish. This slows down peristalsis, the wave-like contractions that propel stool through the intestines, directly leading to constipation. Conversely, high calcium levels, hypercalcemia, can also dampen gut motility. Fluid imbalance and dehydration. Electrolytes are key regulators of the body's hydration status. Dehydration, a common underlying factor in constipation, can result from or be exacerbated by electrolyte imbalances. When the body is low on fluids, it reabsorbs more water from the stool and the colon, making it hard, dry, and difficult to pass. The hypertension-constipation conundrum, a double-edged sword. The relationship between high blood pressure, hypertension, and constipation is a classic example of a vicious cycle. How hypertension can fuel constipation. Medication side effects. This is a major culprit. Many commonly prescribed antihypertensive medications can directly lead to constipation. Calcium channel blockers, CCBs. Drugs like amlodipine or diltiazem relax blood vessels to lower blood pressure, but they also relax the smooth muscles of the intestines, thereby slowing bowel transit. Beta blockers. While less prominent than CCBs, some beta blockers, e.g., metoprolol, atenolol, propranolol, can also contribute to slowed gut motility. Diuretics. These water pills help remove excess fluid, which is crucial for blood pressure management, but can lead to dehydration if fluid intake isn't adequately maintained, resulting in harder stools. Shared lifestyle factors. Both conditions often stem from similar lifestyle choices, such as a diet low in fiber, insufficient fluid intake, and a lack of regular physical activity. Autonomic nervous system dysregulation. Hypertension is linked to imbalances in the autonomic nervous system, which controls involuntary bodily functions including both blood pressure and gut movements. How constipation can aggravate hypertension and cardiovascular risk. The Valsalva maneuver. This is the most critical link. When straining to pass a hard stool, individuals perform a Valsalva maneuver, forcefully exhaling against a closed airway. This dramatically increases intrathoracic pressure, which temporarily reduces blood flow back to the heart. Upon release, there's a sudden, sharp surge in blood pressure. For someone with pre-existing hypertension or underlying heart disease, this acute spike can be dangerous, potentially triggering. Cardiac arrhythmias, irregular heartbeats. Myocardial infarction, heart attack. Stroke. Aortic dissection, a tear in the body's main artery. Worsening of heart failure symptoms. Gut microbiome alterations. Chronic constipation can lead to an unhealthy imbalance in the gut bacteria, dysbiosis, which growing evidence suggests can contribute to systemic inflammation and influence blood pressure regulation. This interconnectedness highlights why managing constipation is a vital part of comprehensive care for individuals with hypertension. Congestive heart failure, CHF, and constipation, a shared burden. Patients with congestive heart failure are particularly vulnerable to constipation due to overlapping factors. Medication regimens, like hypertension, CHF management heavily relies on diuretics, which can cause dehydration. Additionally, CHF patients may be on beta blockers, opioids for pain management, notorious for constipation, or iron supplements for common anemia, all of which contribute to slowed bowel movements. Physiological impact of CHF. Reduced cardiac output in CHF can lead to blood pooling, congestion, and fluid retention, edema, in the intestinal walls, impairing gut motility. Decreased blood flow to the gut due to heart failure can also affect its function. Lifestyle limitations, fatigue, shortness of breath, and limited mobility common in CHF patients often lead to reduced physical activity, lower fluid intake, due to fluid restrictions, and a diet less rich in fiber, all direct causes of constipation. The Valsalva risk. The straining associated with constipation poses a significant cardiovascular risk to a weakened heart, potentially exacerbating CHF symptoms and increasing the likelihood of hospitalizations. Structural and mechanical complications. The physical toll of straining. The repetitive physical stress of chronic straining can lead to significant structural damage. Hemorrhoids. These are swollen, inflamed veins in the anus and lower rectum. Chronic straining significantly increases pressure in these veins, causing them to bulge, become irritated, and often bleed. Anal fissures. Hard, dry stools and forceful straining can tear the delicate skin lining the anus, creating extremely painful fissures that often bleed. The pain from fissures can then cause individuals to avoid defecation, worsening constipation in a self-perpetuating cycle. Rectal prolapse. This occurs when part of the rectum turns inside out and protrudes through the anus. Chronic, forceful straining severely weakens the pelvic floor muscles and the ligaments that normally hold the rectum in place, allowing it to telescope out. Hernias. Inguinal, umbilical, hiatal, incisional. A hernia is when an organ or tissue pushes through a weak spot in the surrounding muscle or connective tissue. The immense, repetitive increase in intra-abdominal pressure from chronic straining is a major risk factor for developing hernias. This can include inguinal hernias, common in the groin. Umbilical hernias, near the belly button. Hiatal hernias, when part of the stomach pushes into the chest through the diaphragm. Incisional hernias, at sites of previous surgical incisions. The relationship can be bidirectional. While straining causes hernias, a large or incarcerated hernia can, in turn, physically obstruct the bowel, leading to or worsening constipation. Diverticulosis/diverticulitis. Chronic straining and high pressure within the colon are believed to contribute to the formation of diverticula, small, bulging pouches on the colon wall, diverticulosis. If these pouches become inflamed or infected, diverticulitis, it can lead to severe abdominal pain and other complications. Pelvic floor dysfunction, PFD. A complex dance of cause and effect. The pelvic floor is a group of muscles that support the pelvic organs and are crucial for bowel control. Here's another vicious cycle. PFD causing constipation, often termed dyssynergic defecation. This occurs when the pelvic floor muscles paradoxically contract or fail to relax properly during a bowel movement. This prevents stool from exiting smoothly, even if it's soft, leading to straining and a feeling of incomplete emptying. Constipation causing PFD, chronic, forceful straining to pass hard stools physically damages, weakens, or overstretches these vital pelvic floor muscles and nerves. This damage can then disrupt their normal coordination, causing or worsening dyssynergic defecation and other forms of PFD, such as rectocele, where the rectum bulges into the vagina. Irritable bowel syndrome constipation, IBS-C. The painful side of chronic constipation. While the article thus far has focused on chronic constipation in general, often referred to as chronic idiopathic constipation or CIC when no clear cause is found, it's crucial to acknowledge a distinct, yet common, subtype, irritable bowel syndrome with constipation, IBS-C. Many individuals experiencing chronic constipation may, in fact, have IBS-C, often characterized by a more prominent symptom, pain. What is IBS-C? IBS-C is a functional gastrointestinal disorder primarily defined by recurrent abdominal pain that is associated with constipation. Unlike CIC, where constipation is the main concern and pain, if present, is not consistently related to bowel movements, IBS-C patients experience abdominal discomfort or pain that often improves after a bowel movement. It's considered a disorder of brain-gut interaction, meaning there's a disconnect in how the brain and gut communicate. Key features and mechanisms of IBS-C. Altered gut motility. Similar to other forms of constipation, transit through the colon can be slow in IBS-C. Visceral hypersensitivity, a hallmark of IBS. This means the nerves in the gut are overly sensitive, causing normal sensations, like gas or stool movement, to be perceived as painful. Gut microbiome dysbiosis. Imbalances in gut bacteria are increasingly linked to IBS-C symptoms, potentially contributing to inflammation and altered gut function. Psychosocial factors, stress, anxiety, and depression can significantly influence the brain-gut axis, exacerbating IBS-C symptoms, and vice versa. Symptoms of IBS-C. Patients with IBS-C commonly report chronic constipation, infrequent, hard, or difficult to pass stools. Recurrent abdominal pain, cramping, or discomfort, often relieved by defecation. Bloating and abdominal distension, feeling swollen or gassy. Excessive gas. Straining during bowel movements. A feeling of incomplete evacuation. Overlapping complications. Many of the structural and mechanical complications discussed earlier, hemorrhoids, anal fissures, rectal prolapse, fecal impaction, are also prevalent in IBS-C patients due to chronic straining and the impact of hard stools. The persistent abdominal pain can further contribute to a reduced quality of life and significant psychological distress. Specific management strategies for IBS-C. While general constipation management, fiber, fluids, exercise, is foundational, IBS-C often requires more targeted approaches. Dietary modifications. Beyond general fiber increase, some individuals find relief with specific diets like the low FODMAP diet, which temporarily restricts certain fermentable carbohydrates that can trigger symptoms like bloating and pain. Medications targeting IBS-C. Secretagogues, e.g., linaclotide, lobeprostone, plecanatide. These medications work by increasing fluid secretion into the intestines, softening stool, and often improving abdominal pain. Laxatives, osmotic laxatives, like PEG, are often used. Antispasmodics may be prescribed to help reduce abdominal cramping and pain. Antidepressants. Low-dose certain antidepressants can modulate pain perception and gut motility at lower doses than those used for mood disorders. Gut-directed therapies. Probiotics. While individual responses vary, some specific strains may help modulate the gut microbiome. Pelvic floor physical therapy, crucial if dyssynergic defecation coexists. Psychological therapies. Techniques like cognitive behavioral therapy, CBT, hypnotherapy, and stress management can be very effective in managing symptoms by addressing the brain-gut connection. Recognizing IBS-C as a distinct entity is vital for accurate diagnosis and providing appropriate, often more specialized, treatment to manage both the constipation and the often debilitating abdominal pain. Other significant problems, beyond the physical. The impact of chronic constipation extends to broader health and well-being. Fecal impaction, a severe complication where a large, hard mass of stool becomes stuck in the rectum or colon, leading to partial or complete bowel obstruction. This can cause severe pain, overflow diarrhea, and, if left untreated, serious complications like bowel perforation, a tear in the intestine, or urinary retention. Reduced quality of life, persistent abdominal pain, bloating, discomfort, fatigue, and the constant worry about bowel movements can profoundly affect daily activities, social interactions, and overall mental health, leading to anxiety and depression. Colon cancer, debated link. While not as direct as the link to hemorrhoids, some theories suggest that prolonged contact between stool and the colonic lining due to slow transit time might increase exposure to potential carcinogens. However, research findings are inconsistent, and constipation can also be a symptom of underlying colon cancer. Comprehensive management strategies for chronic constipation. Given the far-reaching and often debilitating consequences, chronic constipation should never be ignored. Effective management strategies are crucial and often involve a multi-pronged approach aimed at relieving symptoms and preventing complications. Dietary changes. Increasing fiber intake is paramount. Aim for a gradual increase of both soluble fiber, found in oats, apples, beans, peas, which helps soften stool, and insoluble fiber, found in whole grains, vegetables, wheat bran, which adds bulk. It's important to increase fiber gradually to avoid bloating and gas. Adequate fluid intake. Drinking plenty of water throughout the day is essential, as fiber needs fluid to work effectively. Aim for at least 8 glasses, 64 ounces, of water daily, and more if you are very active or in a hot climate. Juices like prune juice can also be helpful for some individuals. Regular physical activity. Engaging in regular exercise, even moderate activities like walking, help stimulate the natural contractions of the intestines, peristalsis, which aids in moving stool through the colon more efficiently. Aim for at least 30 minutes of moderate activity most days of the week. Medication review. It is critical to discuss all medications you are taking with a healthcare provider. They can identify any drugs contributing to your constipation and may suggest alternative medications or adjust dosages if possible. Never stop or change medications without medical advice. Laxatives. When appropriate, used under medical guidance, different types of laxatives can help. Bulk-forming laxatives, e.g., psyllium, methylcellulose, absorb water to make stool softer and bulkier. Osmotic laxatives, e.g., polyethylene glycol, PEG, magnesium hydroxide, draw water into the colon to soften stool. Stool softeners, e.g., docusate sodium, add moisture to stool. Stimulant laxatives, e.g., bisacodyl, senna, work by causing the intestines to contract. These should generally be used short-term or under strict medical supervision to avoid dependence. Pelvic floor physical therapy, especially beneficial for dyssynergic defecation. This therapy often involves biofeedback. Biofeedback helps individuals learn to relax and coordinate their pelvic floor muscles correctly during bowel movements through real-time feedback from sensors. This retraining can significantly improve defecation mechanics. Addressing underlying conditions. If constipation is a symptom of another medical condition, e.g., hypothyroidism, diabetes, electrolyte imbalances, neurological disorders, then diagnosing and specifically treating that primary condition is fundamental to resolving the constipation. Understanding the complex web of effects associated with chronic constipation underscores the importance of proactive management. It's not just about regularity, it's about safeguarding overall health and well-being. Conclusion: taking chronic constipation seriously. In summary, chronic constipation is far more than a mere inconvenience. It is a significant health issue with profound and far-reaching systemic impacts. We've explored how it creates and exacerbates dangerous, vicious cycles, directly influencing conditions such as hypertension, congestive heart failure, and various forms of pelvic floor dysfunction. The physical toll, from hemorrhoids and anal fissures to hernias and diverticulitis, highlights the direct structural damage that persistent straining can inflict. Moreover, complications like fecal impaction and the debilitating impact on overall quality of life, mental health, and even a debated link to colon cancer underscore its seriousness. Crucially, we've delved into the myriad of factors contributing to chronic constipation, ranging from common lifestyle habits and medication side effects to various underlying medical conditions. Understanding these diverse causes is the essential first step toward effective intervention. The good news is that recognizing the gravity and widespread influence of chronic constipation, coupled with an understanding of its roots, empowers us to act. Proactive and comprehensive management strategies are vital. These involve a multi-pronged approach encompassing essential lifestyle modifications like dietary fiber and adequate hydration, regular physical activity, careful medication review, appropriate use of various laxative types, specialized pelvic floor physical therapy, and diligently addressing any underlying medical conditions. Ultimately, taking chronic constipation seriously is about more than just achieving regularity, it's about safeguarding overall health and enhancing long-term well-being. By embracing a holistic approach to understanding and managing this condition, we can break its detrimental cycles and significantly improve lives.